You know, in the clinical lab, some bacteria are just masters of disguise. Today, we're pulling the mask off one of the most convincing imposters out there, Staphylococcus lugdunensis. It has this tricky habit of masquerading as other, more familiar bacteria, and, that misidentification can lead to some really serious consequences. So let's dive into why that is.
I mean, this quote from the literature really just hits the nail on the head, doesn't it? It perfectly captures what Staphylococcus lugdunensis is all about. On the surface, it might look like just another common, less threatening staphylococcus, but hiding right underneath is the virulence of a major league pathogen. And that's really the central theme we're going to be exploring today.
Just so you know, all the information we're about to cover has been synthesized from a comprehensive Gemini deep search. So if you want to geek out and go through the primary literature for yourself, you can find a full list of all the citations in the linked notebook document. Okay, so here's what we've got on tap. We're going to start with exactly why Staphylococcus lugdunensis is this wolf in sheep's clothing, and more importantly, how to unmask it in the lab. Then we'll get into the severe consequences of infection, the right way to treat it, and finally, we'll cover the absolutely critical details of susceptibility testing and infection control. All right, first up, let's get right into the thick of it, the diagnostic dilemma this organism throws at us. Why do we call it a wolf in sheep's clothing? Well, the confusion starts right there at the lab by. So what exactly is this bug? Well, on paper, Staphylococcus lugdunensis is classified as a coagulase-negative staphylococcus, but let me tell you, that label is dangerously misleading. Unlike most of its coagulase-negative relatives, which are often pretty low-grade, this organism can cause infections with a ferocity that is almost a dead ringer for the notorious Staphylococcus aureus. And this right here is where things get really tricky. It's the coagulase paradox. See, Staphylococcus lugdunensis has a bound coagulase or clumping factor, so those rapid slide or latex tests, they often come up positive, making you think you've got Staphylococcus aureus. But then you run the definitive tube coagulase test and it comes back negative, correctly classifying it as a coagulase-negative staph. This discrepancy is a huge trap. An initial mis-ID of Staphylococcus aureus can lead to the wrong treatment, while that final correct idea as a coagulase-negative staph might cause a clinician to just write it off as a simple skin contaminant. What a mess, right? Okay, so how do we sidestep this massive diagnostic headache? Let's talk about how to properly unmask this imposter, moving from those classic benchtop clues all the way to modern proteomics. This is the million-dollar question, isn't it? It's the question every single microbiologist and clinician has to ask when this bug pops up, especially from a sterile site like a blood culture. The answer can literally change a patient's entire outcome, so making the right call is absolutely essential. If you've been around the lab for a while, you start to pick up on some of the telltale signs. Under the microscope, it's your typical gram-positive cocci clusters. But on the plate, the colonies are pretty distinct. They're medium to large, kind of sticky, and they can have this yellow or tan pigment that can really fool you into thinking it's Staphylococcus aureus. It also shows a nice, prominent beta hemolysis that sometimes you have to wait 48 hours to really see it pop. And hey, for those of us with a good nose, many isolates give off this really unique, sweet, almost hay-like smell. But beyond just looking at it, two simple biochemical tests can give you a highly reliable signature. Staphylococcus lugdunensis is positive for both pyrrolidinoyl alamidaceae, or PYR, and ornithine decarboxylase, ODC. That combination right there is a super powerful way to tell it apart from Staphylococcus aureus and most other coagulase-negative staphylococcus. This table really lays it all out for us, side by side. The negative tube coagulase separates it from Staphylococcus aureus, but it's that double positive for PYR and ODC that truly makes it stand out, setting it apart from both Staphylococcus aureus and the other coagulase-negative staph. And look, it also doesn't ferment mannitol, another clear giveaway that it's not Staphylococcus aureus. Thankfully, in most modern labs, we have some fantastic tools that just cut right through all this confusion. MALDI-TOF mass spec gives you a rapid and super accurate protein fingerprint. It's really the method of choice these days. For absolute definitive confirmation, you can use a species-specific PCR that targets its unique FBL gene. And of course, for those really tricky cases or for research, gene sequencing is always the final word. So we figured out how to nail the identification. But why is it so incredibly important to get it right? Well, that brings us to Section 3, the severe clinical consequences and the real impact of this pathogen. Yeah, it can cause skin and soft tissue infections. That's the most common thing you'll see.
But that's just the tip of the iceberg. Staphylococcus lugdunensis is notorious for causing this highly aggressive, really destructive form of infective endocarditis. It can cause devastating bone and joints infections, tenacious biofilm infections on medical devices, and even severe CNS infections, especially in patients with VP shunts. And if you need one number to really drive this home, here it is. The mortality rate for native valve endocarditis caused by Staphylococcus lugdunensis can be as high as 40%. That's just staggering. It puts it right on par with Staphylococcus aureus, and this is exactly why it can never, ever be dismissed as a simple contaminant. With that kind of virulence, the game plan has to be crystal clear. If it acts like Staphylococcus aureus, you have to treat it like Staphylococcus aureus. Which brings us to our guideline-driven treatment strategies. Okay, let's talk about the number one rule here, the absolute cornerstone of treatment: aggressive source control. For things like abscesses, deep-seated infections, or anything involving prosthetic material, antibiotics by themselves are often just not going to cut it. Early, decisive, surgical intervention, we're talking debridement of infected tissue or yanking out that infected device, is absolutely key to getting a good outcome. Let's take a look at the Dutch SWAB guidelines for a concrete example. You'll see they often just group Staphylococcus lugdunensis right in with Staphylococcus aureus. So for a methicillin-susceptible or MSSA-like endocarditis, the therapy is high-dose IV flucloxacillin for 6 weeks straight. If it's methicillin-resistant or MRSA-like, then vancomycin, guided by therapeutic drug monitoring, is the standard of care, again, for at least 6 weeks. And you'll see these same core ideas reflected in international guidelines, too. Simple skin stuff, oral antibiotics plus drainage usually does the trick. But for severe, susceptible infections, beta-lactams like cefazolin or oxacillin are actually superior to vancomycin. And here's a really important stewardship point. A pretty good chunk of Staphylococcus lugdunensis isolates are still susceptible to good old penicillin G. If that susceptibility is confirmed, using that narrow-spectrum agent is definitely the best move. Now, what about kids? Well, for the pediatric population, a lot of this is extrapolated from adult Staphylococcus aureus guidelines, since specific data is a bit more scarce. Dosing, of course, is all wheat-based. Cefazolin and oxacillin are the workhorses for susceptible infections, and vancomycin is held in reserve for empiric coverage or confirmed resistance. In these cases, it's always a good idea to consult with a pediatric infectious disease specialist. All right, we're on the home stretch, and this last part is all about making sure our treatments actually work. This is the patient safety imperative of susceptibility testing and infection control. Okay, everyone, listen up. If you remember nothing else from this entire explainer, please remember this. When you are performing antimicrobial susceptibility testing on Staphylococcus lugdunensis, you must interpret the results using Staphylococcus aureus breakpoints. Do not use the general coagulase-negative staph breakpoints. If you use those more lenient breakpoints, you risk calling a resistant bug susceptible, and that leads to treatment failure. This is a huge, non-negotiable patient safety issue. And you can see that principle in action right here with the EUCAST breakpoints. Notice that methicillin resistance is screened with a cephatoxin disc, as it should be. For penicillin, a smaller zone size is your clue for penicillinase production. And really importantly for clindamycin, a D-test is absolutely essential to check for any inducible resistance. And finally, let's wrap up with infection control. The logic here is simple. We treat it just like Staphylococcus aureus. Rigorous hand hygiene is, as always, number one. For any patient with methicillin-resistant Staphylococcus lugdunensis, or MRSL, you need to implement full contact precautions. Thorough environmental cleaning and targeted decolonization for high-risk patients, just like you would for MRSA, are key to stopping it from spreading. So, when you boil it all down, Staphylococcus lugdunensis is a uniquely virulent pathogen that absolutely commands our respect. Which leaves us with a final question for you to think about. How will this wolf in sheep's clothing change your approach the next time a coagulase-negative staphylococcus pops up from a critical site? Hey, thanks so much for sticking with me through all that. We really hope you'll subscribe for more expert explainers just like this one. And please share your own experiences or your hospital's protocols for dealing with Staphylococcus lugdunensis down in the comments. You know, this kind of collaborative discussion really helps all of us get better at managing this important pathogen.